The term epileptic encephalopathy refers to a group of disorders in which the unremitting epileptic activity contributes to progressive cerebral dysfunction, which cannot be explained by the underlying etiology alone. There are some common features of epileptic encephalopathies, like it has early age of presentation. In EEG, we can see some paroxysmal activity. These seizures are multiform and which are resistant to the conventional anti-epileptics, and there is severe cognitive, behavioral, and neurological deficits. We can classify the epileptic encephalopathy based upon the age of onset. In neonates, there is early myoclonic encephalopathy and Uehara syndrome. In infants, there is epilepsy of infancy with migrating focal seizures, then Dravid syndrome, and then West syndrome. In children, there is Lennox-Gastaut syndrome, the Landau-Kleffner syndrome, and epilepsy with continuous spikes and waves during slow wave sleep. Early myoclonic encephalopathy. These are present within 2 months of age. Etiology, the most common cause is non-ketotic hyperglycemia. Then there is methylmalonic acidemia, then Zellweger syndrome, and pyridoxine deficiency. These are mostly because of inborn error of metabolism. In this early myoclonic encephalopathy, we can see that there is myoclonic seizures are most prominent. The tonic seizures are less frequent. Interictal EEG shows burst suppression, which is which are more in sleep. Treatment, as far as treatment, we can go for pyridoxine, folinic acid, ketogenic diet can be tried. Prognosis is poor. More than 50% child died within weeks or months. Then early infantile epileptic encephalopathy or Uehara syndrome. These are onset from 2 months of age. There is frequent tonic spasms and progressive encephalopathy. In case of early myoclonic encephalopathy, there is only myoclonic seizures, but here is the tonic spasms are seen. The causes are the structural brain disease, and there are some genetic causes also. Structural brain diseases like hemimegalencephaly, focal cortical dysplasia, and Aicardi syndrome. Genetic cause, there is syntaxin binding protein 1 mutation and ARX gene mutation. Here the myoclonic seizures are very rare. Interictal EEG shows burst suppression with no sleep waves differentiation. In EEG, we can see that there is spikes and high amplitude waves in the EEG, and then there is suppression of the electrical activity. There is no definitive treatment, but vigabatrin and zonisamide can be tried. They are mostly disappear within 6 months, but sometimes can progress to West syndrome. In infancy, there is epilepsy of infancy with migrating focal seizures. Onset is less than 6 months, which are very rare, and frequent migrating polymorphous intractable focal seizures lead to psychomotor retardation. Interictal EEG shows multiform epileptiform discharge with slowing of background activity. In EEG, there is no burst suppression. These are difficult to control with conventional anti-epileptics, but we are now trying stiripentol and potassium bromide. West syndrome, which is epileptic spasms. This is a classical triad, shows epileptic spasms or salam attacks, hypsarrhythmia on EEG, and there is developmental regressions. Onset is between the 2 to 12 months of age. What is epileptic spasm? Epileptic spasm is clusters of sudden, brief, which is less than 2 seconds, tonic contractions of axial and limb muscles. These contractions are more in flexor muscles than the extensors. These clusters are usually 10 to 100 per day. What are the precipitating factors? These are drowsiness or upon arousal from sleep or feeding. Interictal EEG shows hypsarrhythmia. Hypsarrhythmia is the chaotic background with bilateral asynchronous high amplitude slow waves and spikes. Ictal EEG shows high voltage generalized slow wave with electrodecremental response. Then there are two types of West syndrome. One is cryptogenic and then another is symptomatic. In cryptogenic, there is normal development before the onset of the seizures, and in symptomatic, there is preceding developmental delay, maybe due to some perinatal asphyxia. What are the treatments? Treatments are ACTH are the drug of choice, and it is usually given at 150 unit per meter square once daily for 2 weeks. Then oral steroid can be given. We can try vigabatrin. Usually it is a second line drug, but in case of tuberous sclerosis with West syndrome, it is a drug of choice. Ketogenic diet can be tried for 3 months, and in intractable cases which are resistant to the pharmacological therapy, we can go for total callosotomy. Prognosis is good if we can treat early, but this may progress to Lennox-Gastaut syndrome in 2 to 4 years, and there is severe psychomotor retardation. Now, Dravid syndrome. Dravid syndrome onset is 5 to 8 months. 50% cases are genetic, which may be due to SCN1A loss of mutation, and then SCN2A mutation, SCN1B mutation. Seizures. These are usually infantile febrile chronic convulsions, which are recurrent and which are recurrent than the normal febrile seizures, in which there is the myoclonic jerks are more than 1 year age. When the child goes to 1 year age, then we can see that there is myoclonic jerks, there is atypical absence seizures, and there is complex focal seizures. And at the age of 2 years, we can see that there is severe psychomotor retardation. Interictal EEG, there is no specific finding in EEG, but it is usually normal till 18 months of age. But we can see that there is abnormal slow background with frequent asymmetrical paroxysms or polyspikes. How we can treat the Dravid syndrome? These are usually refractory to the conventional AEDs. We can go for valproate and clobazam. Stiripentol is recently approved drug, which can be beneficial. The drugs which are contraindicated are phenytoin, carbamazepine, and lamotrigine. These are sodium channel blocker which can worsen the seizure activities. Ketogenic diet is beneficial, and recently FDA approved cannabinoids for the treatment of Dravid syndrome, which can be given to the child who are more than 2 years. Then Lennox-Gastaut syndrome. Onset is usually 1 to 8 years of age, peaks at the age of 2 to 5 years. Etiology, these are usually idiopathic or symptomatic. There may be some encephalitis or tuberous sclerosis or cortical dysplasia. These are multiple refractory seizures, including tonic, atonic, atypical absence, and myoclonic. Drop attacks sometimes may occur, which can injure the child. Interictal EEG shows bilateral, synchronous, slow, generalized spike wave discharge, which are less than 2.5 Hz. Ictal EEG, there is paroxysmal fast activity of 10 to 20 Hz, which are frontally dominant. Usually, in case of NREM sleep, we can see that there is K complex and shift indices, which are absent in case of Lennox-Gastaut syndrome. In treatment, we can go for valproate and clobazam, which are the first line drug. Then we can add zonisamide, rufinamide, lamotrigine, and topiramate. Steroid and IVIG can be given in case of status epilepticus. Ketogenic diet is beneficial, which are refractory to conventional AEDs. And in case of if the pharmacological therapies are failed, then we can go for corpus callosotomy or vagus nerve stimulation. Prognosis is usually bad. 10 to 30% can develop from West syndrome. Mortality is 5%, and in 90% cases, seizure can be seen in adult life also. Then Landau-Kleffner syndrome. Onset is usually 3 to 6 years. Etiology is unknown. There may be some genetic cause, which is GRIN2A mutations. The first symptom is usually verbal auditory agnosia in a previously normal child. Later, the child can develop all type of aphasia and may become mute. Seizures can occur in 75% of cases. There may be cognitive and behavioral problem which may lead to ADHD. EEG shows posterior temporal epileptiform discharges which are multifocal and persist both in REM and NREM sleep. The treatment is usually valproate, benzodiazepine like clobazam and ethoxyximide can be given. Phenytoin and carbamazepine, which are sodium channel blocker, may worsen the EEG discharge. ACTH and steroid can be given if the conventional AEDs are failed. The role of IVIG and ketogenic diet is doubtful. Now, epilepsy with continuous spikes and waves during slow wave sleep. The onset is usually from 2 months to 12 years of age, which are peaks at 4 to 7 years. The symptom is usually the seizures in 80 to 100% of cases, and there may be neuropsychological deterioration. The seizures are mostly in night, which are myoclonic and generalized tonic-clonic seizures and focal seizures. The interictal EEG shows focal or multifocal epileptiform discharge, which are more increases in sleep, in NREM sleep. The EEG shows continuous bilateral 1.5 to 3 Hz frontally predominant continuous spike and waves during slow wave sleep. In epilepsy with continuous spikes and slow waves, we can see that the spikes are usually frontally dominant, but in case of Landau-Kleffner syndrome, the spikes are temporally dominant. Etiology. It is usually not known, but there may be some abnormal neuroimaging in 40% of cases. Treatment. ACTH can be tried. We can give steroid also, and IVIG can be given. There may be benzodiazepine like clobazam and valproate we can add, and that is beneficial. To sum up the epileptic encephalopathies, we can classify it into 3 groups: neonates, infants, and children. In neonates, there is epileptic myoclonic encephalopathy and Otahara syndrome. In EME, it is the most common cause is inborn error of metabolism, and these are the there is myoclonic seizures and there is no tonic spasm. In case of Otahara syndrome, the most common structural abnormalities is the most common cause, and there is tonic seizures are seen, but rarely we can see that there is myoclonic jerks. In case of infants, there is Dravid syndrome and West syndrome. Dravid syndrome, the most common mutation is SCN1A, and there is atypical febrile seizures are seen. The recently approved drug is stiripentol. In West syndrome, there is classical triad of infantile spasms, hips arrhythmia, and neurological developmental delay. In 30% of cases, it may lead to Lennox-Gastaut syndrome. The drug of choice is ACTH. In children, there is Lennox-Gastaut syndrome, in Landau-Kleffner syndrome, and continuous spikes in slow wave sleep. In Lennox-Gastaut syndrome, we can see that there is multiple type of seizures, and EEG shows generalized slow wave discharge with paroxysmal fast activity. In Landau-Kleffner syndrome, there is verbal or auditory atnosia, and in 75% of cases, there is seizures. The spikes are mostly in the temporal region. In CSWS, the seizures is mostly in 80 to 100% of cases, which are the EEG shows spikes which are mostly frontal dominant, and there is expressive aphasia, that is the Broca's aphasia.